We record these meetings just for note taking. And we also have a number of people who couldn't join us today, so may end up sharing it with them so that they can benefit later. So our first item of business, as always, is to approve the minutes from the last meeting. I sent out yesterday the draft of minutes from the last meeting. And I did receive one piece of feedback that there's one person we didn't capture on the attendee list, so we'll make that change. But other than that, does anyone else have any amendments?
Becca, I move to approve the minutes of the July 23rd, 2024 Value Plan Work Group as amended. This is Evelyn.
Thanks, Evelyn.
I second.
Thanks, Emily. Okay, great. So if there are no opposed, then we have finalized we've approved the 2020 or the July 23rd minutes from that meeting. Okay, great. Thanks, everybody. So our agenda today, we've already done the minutes, and the bulk of our meeting today, we're very fortunate to be joined by Camille Blake Fall and Dr. David Mann from the Office of Minority Health and Health Disparities at the Maryland Department of Health. So today we're going to be mostly just hearing from them and then thinking about how we can apply what we are learning from them to future plan designs. And it is kind of too late for us to apply things that we learned from them to the 2026 designs, but since this is a recurring annual work group, this will be good for thinking further ahead and also, perhaps confirming decisions that we're considering making on the 2026 plans. But again, not too many changes to be made there. Yes, here's the objective slide yet again. So our goals today are just to hear this presentation from the Office of Minority Health and Health Disparities, and then talk about how we can apply that in the future. So unless anyone has any other items of business, I'm happy to turn things over to Camille and David. And I have your slides here if you want me to run them for you, but I'm also happy to turn over the controls to you. So it's just what you prefer.
Why don't I go ahead and share them that way I can use the cursor as a pointer for some of the graphics.
Great, thank you so much.
Well, before David, Dr. Mann jumps in with some of the really salient data points that I think are important when we talk about health disparities and health equity. I just will take a minute, if you don't mind, and introduce myself. I'd also love to know who all comprises the work group. I'll tell you a little bit about the work of our office for those who are unfamiliar. Put a plug in for our upcoming December annual Health Equity Conference, which will happen December 10th, celebrating 20 years of this office. Run a bit through the mission, the vision, talk a little bit more about the newest iteration of health equity consideration or health equity focus, and that's under our HEAD model, which is our new global payment model that we recently, system model that we've recently been awarded by the Center for Medicare and Medicaid Services. And there's really a discussion and a focus on health equity there. Talk briefly about that. And then I will turn it over to Dr. Mann, who will sort of take you through some of the data that I think will help inform, hopefully, what you're thinking about for 2027 and beyond. Just a point of clarity for 2026, while that's pretty much in the bag, did you make any adjustments? Did you change your plan benefits to reflect any current thinkings around equity? I know previously diabetes was something that you were able to address. Wondering if there's anything coming up in the immediate future.
Yes, good question. So we are continuing the diabetes cost sharing. And then what the group has discussed this year is reducing copays for labs, lab services, as much as the actuarial value limitations will allow. We discussed kind of this idea of reducing cost sharing for conditions versus for specific conditions versus specific services. So like the condition-based approach is what DC is doing and what we've done with diabetes. But DC has added more and more over the years, like pediatric mental health and cardiovascular and cerebrovascular disease care. And then a service-based approach is, like we're considering with labs. This is something that other states have done, for example, Connecticut. And the idea is it allows for kind of people with maybe multiple comorbidities that happen to be, that often are high disparity conditions, chronic conditions. They're able to benefit from that. And that's promoting equity just in a different way. And the reason we are steering away from the condition-based approach is because of the kind of logistical challenges in terms of the cost sharing being dependent on providers using certain diagnosis codes. And if the provider isn't aligned, then that patient might miss out on the cost sharing, and it's just very complicated to implement. So we wanted to do something that would have kind of a broad impact and not be too logistically difficult to implement. And also, again, just with the limitations in AB, we weren't really able to, consider whole conditions. But that's what we've gone with for 2026 so far. So we're still finalizing those draft plans, but we're looking at reducing the lab code base.
Well, that's great. Thank you for that feedback. I think that will be helpful and illustrative for Dr. Mann as he runs through the data that he'll be presenting. We can introduce ourselves first, and then I'd love to know who's on the call. I am Camille Blake-Fowl. I'm the director of the Office of Minority Health and Health Disparities, which is a name I feel like will evolve because really we talk a lot about health equity, of which disparities is a subset. But we have socioeconomic disparities that may have nothing to do with race or ethnicity. So we all know this on the call, but just been thinking about that and what the mandate is for our office. I've been in the role for about a year now, celebrated my year anniversary July 19th of this year. I can't believe how quickly the time has flown. And like I mentioned at the top of our time together, we will be celebrating 20 years. This year, we are celebrating 20 years, and we'll commemorate that on December 10th at a conference, day-long conference at Morgan State University. So we look forward to having as many of you join us as you can. For those who are not intimately familiar with the work of this office, the mission of MHHD is to help address social determinants of health and now health-related social needs, which seems to be the new lexicon or nomenclature. I do think there's a distinction between there's a difference between health-related social needs and social determinants of health that I think is maybe getting lost in the conversation these days, and I'm happy to share more about that. But we work with the department to address both SDOH and health-related social needs. We look to support the strategy and direction of the department on behalf of the secretary herself. We really prioritize community partnerships through our grant programming. We have 3 grants. We just recently completed our grant cycle, 48 grantees, over $5 million this FY 2025. So we're really excited about being able to reach down and partner with community-based organizations and universities who are doing really important work on the ground at a grassroots level, which we know is where change really happens. I mean, there are lots of ways to support the ecosystem, but really getting in there at the root and sort of supporting patients and individuals and communities, I think is really how we're going to change and improve health equity. We also leverage the resources of the Maryland Department of Health. We support the legislative initiatives. Everything's through an eye or a lens of health equity. Is it equitable? A health in all policies kind of approach is something that's really a priority to me. We've not done a great job across the state of doing that. I think the AHEAD model will help us to do that, as well as other initiatives. Like I mentioned, we've got 3 grant programs that we administer: the Minority Outreach and Technical Assistance Grant Program, the Social Determinants of Health Grant Program, and our last program, which will sunset soon, COVID funding, Epidemiology and Laboratory Capacity, ELC, which was administered, I think, during the height of COVID in FY21 to support community-based efforts for testing and education, and really we're now using those funds to prepare both to maintain sort of testing and awareness, but also preparing, folks for the next pandemic, which we know will come. It's only a matter of time. So that's the basis of, that's basically what our office does. Dr. Mann, do you want to introduce yourselves before we do a round robin?
Sure. Can everybody hear me okay?
Yep.
And so I'm David Mann, and I'm the epidemiologist in the office, and I've been with the office since its inception back in 2004. So I'm a 20-year man in the office, and I pretty much focus on anything math or data related in the office, also help out with some of the mathematical aspects of the grant program administration.
Great. Becca, I know you. I don't know any others, and screens are off, so I'd love if folks would mind introducing themselves.
Yeah, maybe we can start with the co-chairs, and then if everybody, as they're finishing, maybe calls on someone else. That would be a good way to get through the list.
Hi, I'm Emily Hodson. I'm one of our co-chairs this year, and I am a social worker who works at a federally qualified health center. I also work as a navigator for the Maryland Health Benefit Exchange.
Nice to meet you. Wonderful.
Good afternoon. My name is Dr. Evelyn Bryant Ward. I'm the Director of Operations for the University of Maryland Charles Regional. Here in Charles County, I am responsible for the ambulatory group, all of our employed physicians, recruitment, hiring, upfitting medical practices to meet the needs of our communities as they expand and grow. Social determinants of health is one of my big resources for identifying, physician needs in the community.
Thank you.
And then Ken, do you want to go ahead next?
Sure. My name is Ken Brennan. I am the former chairman of the Standing Advisory Committee. My current role is the policy advisor for the Special Olympics Healthy Athletes Program.
Oh, wonderful.
I'll jump in. Matt Celentano, the Executive Director of the League of Life and Health Insurers of Maryland, and I'm sorry I can't have my camera on. Unfortunately, I'm driving.
Nice to meet you.
I can jump in. This is Ashton DeLong. I'm General Counsel for MedChi, the Maryland State Medical Society. Happy to be here.
Great to meet you.
Hi, I'm happy to go next. Stephen Chen, Director of Policy with the Maryland Hospital Association.
Hi there.
Hi, I'll go next. Nikki Blake with Care First Blue Cross Blue Shield. I'm on the policy team at Care First.
Nice to meet you, Nikki.
Good afternoon. Brian Espindola from United Healthcare, and I am the Senior Product Manager for United. It's great to meet everyone.
Good afternoon. My name is Alison Mangiaracino. I'm the Exchange Policy and Operations Manager representing Kaiser Permanente on this work group.
Wonderful. Hello.
Hi, I'm Stephanie Clapper, Deputy Director with the Maryland Healthcare for All Coalition.
Nice to meet you, Stephanie.
I'm Kathleen McGuire. I'm a health policy analyst in the Office of Innovation, Research, and Development with Maryland Medicaid.
Hello. Have we covered everyone?
I'll pop in. I'm Lisa Solomon. I'm a licensed insurance broker with Maryland Health Connection. I'm part of the BAT phone program, and I've been working with the exchange since its inception with the Affordable Care Act. I also work with Medicare as well.
Lovely to meet you. Any other folks? Don't want to leave anyone out. It's really helpful to know, who were, our colleagues on the call. Always helpful to know that. Well, quite quickly, I mentioned a bit ago that we are, and it's incredibly helpful to know who's on the call, because when we think about the next iteration of a global payment scheme to continue the total cost of care, which is sort of what we've been operating under as a state, Medicare and Medicaid reimbursement. We now have the AHEAD model, which I think, and others would probably agree, that the grant program that CMS or the NOFO that CMS published last November really takes what Maryland has been doing quite well for several years, both under all payer and total cost of care, and codified it to some degree, and is now, offering it to other states to replicate a lot of the work, not all of it, but a lot of the work that had been ongoing in Maryland, because Maryland had been, as you all know, the only state with that kind of, global payment system in place. And so it's an honor to continue that work, to receive the award. And really, from my perspective, what's incredibly important about the change to the AHEAD model that didn't exist explicitly, I think it was always indirectly intended when we think about chronic conditions and reducing hospital utilization and all the things that we know our communities, socioeconomically and racially and ethnically may be dealing with, is a real intentional focus around health equity and population health as a way to address and really get at, equitable quality outcomes for all people. And so there's a real intentionality from CMS's perspective to ensure that states are thinking about embedding equity into all aspects of whatever we do in the, individual provider space with physicians or at the hospital level. And this is work that, both the Maryland Hospital Association and others, MDPCP, through their incentives program, folks have been, entities have been looking at health equity and health disparities in our state for quite some time. So certainly this won't be the first introduction of health equity, but it really is the most intentional introduction at a state level, and provides a wonderful opportunity to expand on what we have been doing and course correct when things haven't been working, and really bolster our efforts. So I encourage all of you who may have seen it but haven't submitted tipped your hat or thrown your hat in the ring for participation as part of the AHEAD model's Maryland Commission on Health Equity, which will be the model governance structure that will oversee over the next 9 years. We are in a pre-implementation phase now from July 1 of this year to December of 2025. And so we'll be working and negotiating with CMS about what our measures will be and targets will be and all of that. But part of that also is to develop a statewide, and hospitals will also develop their own health equity plans. We, the MHBE, will help develop a statewide health equity plan. And so there's a call out right now for interested folks who are community-based folks or folks doing work in population health entities to throw their hat in the ring for consideration as a member of this 33-person group. So if you haven't seen that announcement, I'm happy to forward it to you. And I will continue to do work along with Dr. Elizabeth Crom, who heads up our population health, our public FIPA. I never know what that stands for, but it's sort of like the population health arm of our Department of, public health administration. So we'll continue to be doing that work, obviously, along with the secretary and HSCRC. So health equity figures prominently for the state moving forward. And so our office will be, working in lockstep with the secretary to advance CMS's definition of health equity, Healthy People 2030. And the beautiful thing I think that I'm really excited about is that MHBE will develop a health equity definition specific to Maryland, right? So the CMS definition is a floor, not necessarily a ceiling. And I'm really excited about the possibility of really being robust in our efforts. With that, I will turn it over, unless there are any questions, I will turn it over to Dr. Mann, who will take us through some slides, just about less than a dozen, going into detail about the current state of equity and inequity and access and outcomes for individuals across the state over the last, I think, 10 years. His data looks at that. But any questions for me? And I'm happy to take them after as well. All right, hearing none, thank you for your time. Dr. Mann, you're up.
Okay, so moving forward, just so everybody's kind of coming from the same point, definition of health equity, we like the one that Healthy People 2030 uses. It's the attainment of the highest level of health for all people. And I like their emphasis on it requires focusing on addressing avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. Which then brings us to the next question. So what's a health disparity? And again, we like their definition. It's a particular type of health difference that's closely linked with social, economic, and or environmental disadvantage. And we typically see those in groups of people. So any kind of group that we can define by some kind of group identifier who may have systematically experienced greater obstacles to health, that have been linked on historical discrimination or exclusion based on their group status. And here they list a whole variety of potential group identifiers, some of which we have data on, some of which we don't. But clearly it's not an exhaustive list, but it gives you the idea that anytime some group gets treated differently because of who that group is, and that different treatment changes their social opportunities, their economic opportunities, and that's going to influence their health opportunities as well. So moving into some data, since I think one of the charges to us in this presentation was to identify what kind of different disease areas might we have a focus on, where do we have some of the larger disparities, and also I think the other piece of this is, not, besides knowing where the disparities are at, understanding what are the things we can do about them. So ultimately, I think we end up changing bad outcomes by successfully intervening on their root causes. So we'll talk a little bit about what the causal chains of these things look like toward the end of the presentation. But here we've got an example of death rate disparities for stroke. This comes from our Vital Statistics annual report. And what's been unfortunate over the last decade or so is that we've actually, after a long time of seeing these rates come down, as they're starting to actually go back up a little bit in all groups. And the black rate here in the gold line is meaningfully higher than the white rate in the red line. We can see that at the end point here, it's 56.6 per 100,000 versus 38.5. So that's certainly one of our disparity areas. And death rates are one of the metrics that we track, and we see disparities in multiple different diseases. Then moving from mortality, death rates, to hospital utilization, this is information that CRISP is compiling in their Health Equity Explorer. This is what they call their Health Equity Index tool. And here we've got to pull this. We selected Baltimore City, and it pulls out the age-adjusted rates of hypertension hospital encounters. So this combines the ED visits and the hospital admissions. And we see what's the rate, and this is per 100,000. And turns out that the black rate, which is this purple or lavender line, is up here, and the white rate, which is the brown line, is down here. And we can see that that's a multiple here, black versus white. But they set white as a reference of 1. The black rate's twice that. So here, a fairly large gap between the two. Then this is an example of another place we look at disparities, which is in the disease frequency. This happens to be data on the prevalence of disease, how many people have the disease, as distinct from incidence, which is a measure of how many people got the disease in the last years, typically how public health does that. So new cases is incidence, all cases is prevalence. This is tracking prevalence. And here we see that the rate for the Black population for doctor-diagnosed hypertension is up here around probably 38%, and the white rates here probably at about 30% itself. So for the other groups, we didn't see for Asian or Hispanic that there was a higher rate compared to the non-Hispanic whites, but for this other population, which tends to have multiracial and would have the American Indian population, also a higher rate compared to the white population. So we've seen here disparities across, mortality, the death rates, hospital utilization, frequency of the disease. And then the question comes up, where do the social factors fit in? And so this was an analysis we did for our diabetes action plan, where we looked along the x-axis here at different levels of income. So this is income under 15,000 in different buckets up to over 75,000 for household income. And then this is the prevalence of diagnosed diabetes. Here it's, you see that there's not too much difference between the two lowest groups, but then we start to see as income goes up, the prevalence of diabetes tends to go down. So higher incomes tend to do better in general. And that's true for both the Black population and the white population. And the other thing that we see is that for any given level of income, there's a gap between the Black and white population. So clearly there's more going on than just income that's causing the differences between Black and white populations for diabetes prevalence. This is a similar analysis here for educational attainment. And this is less than high school or less than having a GED, all the way up to 4 years of college or more. We can see again, more education is better regardless of the racial ethnic group. And we also see that at any level of this educational attainment, things are worse for the Black population than the white population. So there's clearly things beyond education and income. They're certainly important drivers, but they're not the only drivers, and we have to attack the whole set of drivers as well. So thinking about what we just looked at, mortality rates, which we had here, the morbidity, which would be different kinds of disease severity measures, and also things like disability, blindness, depression, amputation rates, healthcare utilization, which we took a look at, an example of that data, and also healthcare costs, which we can derive from the healthcare utilization data. These outcomes tend to flow from the disease frequency and the disease severity. So we kind of mix these two together and get what this comes out to be. Frequency of disease tends to come from the prevalence of the causes of disease, the risk factors, and the access to and quality of prevention services. So this is one of the levers that you work on in the exchange, the access to services by providing the health insurance. And severity of disease is then a function of the severity of these causes of disease and the access to and quality of the treatment services once someone has the disease. So again, another place where the exchange has a role. And these factors are all derived from this whole panoply of social determinants of health. I won't read the entire list here, but these things are often very correlated by place. The adverse social determinants do tend to cluster in certain places. And this is one of the reasons people often talk about how important place is, and that your zip code may be more important than your genetic code to determining your health outcomes. So I like to think about this as kind of the different places where we can potentially look to not only find data to describe disparities at all these stages, but where can we actually make interventions to try to change what's happening at each of these causal steps? Because if we can improve things here and here and here, we can hopefully improve things down here at the end. So then to just cover some other diseases that have large disparities, just as areas you might consider for your work. Human immunodeficiency virus, HIV, mortality rates, pretty large gaps. We see here that the Black rate most recently 6.8 versus 0.8 for whites. So just under a 10-fold disparity. Although I have to say this is a vast area of improvement, because in 2000, it was a 10-fold disparity at 20 and 2 comparing Blacks to whites. So having a 10-fold disparity that's down to 6.8 versus 8 is certainly a step in the right direction, because that gap in terms of excess mortality has improved. Here's infant mortality, another area we talk about a lot, and we can see that Black rate 9.9 versus a white rate of 3.3, so it's threefold higher this particular time. That ratio is particularly high because the white rate was particularly good for this year. In other years, it's not quite as high. This is more like a 2.5 ratio, but an area that we have a pretty large Black-white disparity to deal with. And some of that comes from the disparity in the prenatal care. So this is a slide looking at the percentage of births to women who received either late prenatal care, third trimesters when it started, or no prenatal care at all. We can see that the Black rate, which is the golden line here, has been higher than the white rate, which is the red line. And interestingly, that the Hispanic line, the gold line here is, I'm sorry, the purple line is actually up in the same range as the Black line, and yet their infant mortality is actually down somewhere in the range approximating what the white rates are. So it tells us that while infant mortality, the prenatal care is important to infant mortality, clearly it's not the only factor, because a group that actually is also having late prenatal care at a high frequency is somehow managing to still avoid the high frequency of the infant mortality outcome. So there's probably something to learn about what other factors could we target to try to improve outcomes besides the prenatal care. This one looks at maternal mortality rate disparities. So we have the Black rates over time in this green line here, and we have the white rates here in the red line. And so clearly a very large gap between these, and maternal mortality has become a very large discussion point in public health of late. I think one thing to keep in mind is that these are rates that are per 100,000 live births, and the infant mortality rates that I reported earlier are all measured per 1,000 live births. If we were to convert Black infant mortality to per 100,000, it would be 1,000 per 100,000. So infant mortality is still many orders of magnitude a larger issue than maternal mortality, although they're both very important. Both have to be addressed, and both of them, fortunately, will probably be addressed by relatively similar kinds of interventions. What works for one is likely to work for the other as well. So that then brings us to this slide, which I think is perhaps very small to see this way. So let me do a little trick here with the screen. So end the show and bring this slide up and then start with the, yeah. So hopefully this is going to make this a little easier to see. Let me see if we're making, yep, they were making some progress there. So this is a series of steps to successful management of chronic disease that we had used with our Health Enterprise Zone program in the past, but I think it's still applicable. So there's all the things that happen before you get to a provider, which is you need to have health insurance so you can afford to get care. Once you've got health insurance, you've got to have a provider who actually takes your insurance. So if we have a lot of people getting enrolled in Medicaid and then no providers in your neighborhood take Medicaid, that's not helpful. So we got to make sure that there's the right provider distribution. That's another part of our department thinks about the healthcare workforce issues. And then you have to be able to get to the provider in a time that works for you. So populations that really are working in jobs that don't have time off for medical care, don't have sick leave, and really would need to try to access care after normal working hours. If no one's available to do that, that creates a barrier as well. So we have to do all these things to try to make sure people can actually get to the provider. And some of the things that we do to do that are linking uninsured persons to the exchange. So that's very important. 50% or more reduction in health uninsurance in Maryland after the exchanges got up and running in 2014. So that's a big success. If we've got problem with getting people into providers, we try to link people who may be insured but without a medical home to providers that can accommodate them. And also we have in the past tried educating people on optimal use of their insurance. So people who are newly insured may need to understand that, you know, use insurance for prevention. Don't just use it to go to the ED when you feel bad. So another piece of education that's important. And then linking insured persons who have transportation barriers to transportation services can be important. So that's another aspect that we can do. And of course, what happens if this doesn't happen, if people don't get to the primary care provider, is they'll use the emergency room for primary care, or they'll delay care, have a chronic disease crisis of some sort, end up in the ED and having a hospital admission or a readmission. Then if we come down here, there's a couple things that happen inside at the provider. So this is our at the provider box. There has to be a good patient-provider interaction so that the patient actually is understanding what the intention is for the treatment plan that's going to come out of that encounter. And this is where we talk about cultural competency training and why that's important to make sure we have this happening. Also, language services for people who have limited English proficiency and have a primary language that's not English. We got to make sure we've got the services there for interpretation and materials that are in multiple languages. And at the end of the day, the provider has to be providing the correct evidence-based treatment plan. That's probably not so much something that the exchange is able to influence, but hopefully the medical profession itself is making sure this is happening. And then when you ultimately step out from the doctor's office, you go home, execution of the treatment plan, which is what makes chronic disease management work, is done by the patient at home. So the physician, the provider, isn't actually treating the chronic disease. The patient is treating the chronic disease at home with a treatment plan. So if that plan doesn't get carried out properly, none of this is going to work. So this is where we think case management and community health worker services to support patient self-management can be really critical. And again, here's all the things that happen if this doesn't happen. So as we think about, you know, where can the exchange have a role in these things. One of the thoughts is certainly you're helping get people insured, which is great, but are there ways in which plan design can be more friendly with community health worker services for chronic disease management support? Is that something that can be built into plan design in some way? I'm not sure I know what the answer is, but I think it's an area to think about and talk about. Is there a way to build a transportation benefit into a plan? I know that I see ads on the television for these Medicare plans that say they're having all these other benefits, including transportation and like a little, almost like a little allowance for some of these health-related social needs issues. So is there some avenue in plan design that might help to deal with transportation barriers or with other health-related social needs in some way. In addition to the primary and big function that the exchange does, which is to make sure that we get people linked to health insurance and make sure that people then can afford to use their health insurance. So to the extent that we can try to minimize co-pays and co-insurance for certain critical services, which if we do that might actually reduce the healthcare utilization at the hospital end, which might provide some cost savings that might help, reimburse for the expense of perhaps reducing some of those co-pays and co-insurance. So that's the last slide we have in our set. And I think this one here was designed to kind of be the springboard for what the discussion of what kinds of equity related interventions within the exchange operation might be useful. And at this point, I think we can take any questions.
I know that's a lot of information, and Dr. Mann and I were happy to go back. Dr. Mann is happy to go back if you wanted to go back to an earlier screen. Yes, Ken, I see your hand.
Yeah, I'm currently working on an initiative that has specific applications for community health workers being the trusted medical resource that crosses the threshold. I wonder if you or Dr. Mann could expand a little bit on anything that you might feel we could do in some of this proposed legislation, or more specifically related to where we are with the value plans. How could we add an element that would enhance the participation of the community health worker?
Well, I'll speak to what I have learned, because since I arrived, the community health worker, sort of really implementing use of the community health worker has been a core passion of mine, and something I've been talking about with the secretary and Dr. Ryan Moran, who runs our Medicaid program, because other states embed reimbursement for community health workers in their Medicaid plans as part of their 1115 waivers, and various states do that in various ways. You can reimburse the hospital or the primary care office. You can reimburse directly the community health worker if they are enrolled as a provider. And so there are all sorts of ways that states are going about it, but it's not a new concept. It's just not one that Maryland has yet undertaken. But certainly, if I think you look to other states' Medicaid programs who are doing this work, you could find the ways that they are embedding it into their reimbursement. That may be a model or a template. I don't know if it's apples for apples will work for us, but it is an idea about like what is possible. What are other states thinking about in terms of reimbursement? I mean, you could reimburse the plan. You could reimburse a plan, and then the money would obviously then trickle down to the provider. But there are all sorts of ways to do it. Dr. Mann, any thoughts?
I think the question would be: is there a model in which the community health worker service is an explicitly covered service, maybe for certain diagnoses or something of that sort? I mean, thinking about where from an insurance plan design issue does this even tie in? So I think the question of could that be set up as a covered service in some way, so that for example, if a community-based organization has hired and has a team of community health workers, then the plan would say that we can have a particular patient use services of that community health worker, and there's a vehicle in the plan for reimbursing that community health worker service. And I think one of the things to maybe make fiscal sense is community health worker services for chronic disease patient self-management. We kind of think of it as someone who knows how to be a really good patient, teaching a patient how to be a really good patient, and they teach them over a 30 to 60 day period and hopefully graduate them out as someone who now is skilled to be their own self-manager. So that the notion isn't that the community health worker becomes a lifetime service that this person needs. It's more of a training to really, how are you going to manage your disease? And we're trying to foster independence in the patient to be the independent self-manager, which I think the idea that there's kind of a time limited 30 to 60 day window of kind of involvement to try to help get the patient up to the point where they're really good at their own self-management kind of contains the cost of community health worker services, which I think makes it fiscally feasible within the insurance environment.
Thank you, Camille, and thank you, Dr. Mann. That's a very pragmatic approach, and I may get in touch with you to explore that a little further.
Yeah, there was a great program for the Prince George's County HEZ that had some great results. They developed some very specific stepwise tracks for the community health workers to do with individual diseases and individual social needs. So there's a whole blueprint for this that Prince George has developed. I don't know if they've ever published it anywhere, but that's something we could see if they've got available for sharing.
Matthew, I see your hand.
Thank you, Camille. Thank you, David, for your presentation. It's really helpful. This might be a fairly amateur question, but could you sort of define the, I guess, maybe scope or practice of a community health worker? Are we talking nurse practitioners or LCSWs or physicians? And is there like a granular example from other Medicaid programs that might apply here?
The thing about community health workers is that there are a couple of community health worker associations. There's a national one and there's in fact an international one. But the thing that I have learned is that there is not one concrete definition of what a community health worker is. It depends on how a practice or a hospital or community-based organization uses that individual. For some practices, they're simply like a secretary, they're intake. For some practices or hospitals, they go out, to Dr. Mann's point, and actually meet community where they are. For some, they really sort of morph. There isn't one definition. It's really whatever is needed in that jurisdiction by that practice or plan or hospital to meet people where they are and to be the bridge as a trusted partner. I don't think the use of community health workers as secretaries and admin staff in a practice, in an office, is the best use, unless you're also coupling that administrative work with some sort of outreach or engagement that the person who's sitting at a desk from 9 to 5 is able to leverage or be a part of. But there isn't a uniform definition, but there are these two, one national, one international association, that really gives you a flavor for all the ways that CHW show up globally and nationally, depending on the communities that they serve.
That's helpful. Thank you.
And I think there's almost a sense of almost a subspecialization of kind of community health worker roles, because I mean, I was just talking about what I think of as the patient self-management support role. How do you take someone with diabetes or high blood pressure and teach them, or asthma, teach them how to navigate what are sometimes complicated treatment plans, especially the ones where we ask you to measure your physiology and then change your medication based on that measurement, which is what we do for diabetes and for asthma. Training people how to do that, that's only one spot, but cancer navigation, getting people who have a positive screening test navigated through hooking up to the healthcare system, that's a whole nother kind of community health worker specialty. Doing initial intake assessments might be another specialty area. So there's almost these different functions that community health workers serve that probably each require a kind of slightly specialized skill set. But the thing I always think about that differentiates community health worker from nurses, social workers, other health professionals who are licensed in other ways, is it's really, you're trying to have somebody who's been recruited from the community that they're going to serve, not someone who gets a degree somewhere and parachutes into that community, because we really want to take advantage of that intimate knowledge of that community and potentially that community's familiarity with that person as a member of the community to really get that trust to really help us with those connections, because sometimes the lack of trust between community and healthcare professionals is one of our biggest barriers.
Yeah, that's really helpful, David. And I think that, I guess the way you guys have presented it is a fluid sort of approach to be able to meet the needs of the community. That really appeals to me. But I'm also thinking of the other side of my brain, if we're going to tie it to reimbursement, I would imagine going to have to define the roles pretty concretely. Let's just say that.
Yeah, I can understand that. I think, from a cost savings measure, from a clarity perspective, from a reimbursement perspective, you would have to do that. Those two associations, I think, are helpful in terms of giving you a broad scope from which you could potentially pick. But you don't want to be so, I would just offer as an idea that we wouldn't want to be so prescriptive so that we can't manipulate the need, we can't manipulate the services for which we reimburse as overlaid against the or onto the community that's being served. What's needed in Dorchester County is going to be very different potentially than what's needed in Baltimore City, than what's needed in Prince George's County. And so how do we build in some flexibility while we're creating a model that that is financially manageable and not unwieldy on all sorts of fronts? And I think that's where the devil would be in the details. Because if you were to say, well, it's just someone who helps with chronic care management, then there are all these other roles that have been incredibly helpful to communities that wouldn't necessarily get covered. And it would move us in a better direction, but it it certainly wouldn't be as expansive as we might hope. I think even like health literacy, I think that's a subset of what David's talking about, getting folks to understand the importance of, preventive care, in a language that they understand. You could hire someone whose sole function as your community health worker is to speak whatever languages are predominate in that jurisdiction. I don't know if I see any other hands. Becca.
This has been great. Thank you so much. Does anyone have any other thoughts on how we can, use this information as we think about 2027 plans?
I'd like to add one other comment, which is we didn't have a slide talking about asthma, but asthma typically has black versus white. ED visit rates in the range of 3 times higher, hospitalization rates 2 to 3 times higher. And what's particularly interesting about the asthma story is that the prevalence of asthma between blacks and white, at least in adults, is only about 20% higher. So the ratio is like 1.2 to 1. But that produces a ED visit rate 3 to 1 and hospital admission rate somewhere between 2 to 1 or 3 to 1. If the success in treating asthma was equal, we'd expect a hospitalization rate and ED visit rate to be 1.2 to 1, just like the basic disease frequency rate. So clearly that's one of the areas where it's not a frequency of disease issue. It's really a treatment success issue that's driving that hospital utilization difference. And what are the ways we can, what things can we do to try to help shrink that treatment success? And treatment success has everything in it, from whether people have insurance, whether people can get to a doctor, and where they can do their treatment plan at home. So all these pre-provider, in-provider, and post-provider things we talked about are applicable to that treatment success story. Something like diabetes is about 50-50. This half of the gap in utilization is probably coming from the treatment success, because it's a little bit more than the frequency difference, but there is a substantial frequency difference. And the HIV data that I showed, interestingly enough, that 10-fold mortality rate difference is driven mostly by the fact that there's a 10-fold disease incidence rate difference between the two groups. Not to say there aren't healthcare disparities in the treatment, and I'm sure there are, but they're probably being dwarfed by the fact that the acquisition of disease is 10 times more frequent in one group than another. So that sorting out of is this problem in utilization coming from disease frequency, or is it coming from treatment success, is one of the things we are able to tease out with data. And for example, asthma, diabetes, hypertension are areas where the treatment success piece is really fairly prominent, asthma especially.
That's fascinating. And something that we think about for our reinsurance program is this issue of high cost and high frequency conditions. And we have the carriers that participate in the reinsurance program report on that every year. And asthma is on there. Pregnancy often is on there. And so that's, something we'll be thinking about more in the future. And I'll probably be in touch with you about how to address that, and why those conditions are showing up, and whether it's something that we can address. So thanks for that. Any other thoughts on this presentation? Based on what Dr. Mann has presented, does anyone have any ideas on anything you'd like to see addressed in 2027 plans?
Hi, it's Emily. This was a great presentation. Thank you guys so much for being here and presenting to us. I think that the information, especially when we talk about case management and community health workers, I specifically am a social worker who does case management and works with a lot of different grants that put us out into the community to help navigate social determinants of health and different disparities, particularly with those who are living with HIV. So I know that it can be very broad to try to tackle some of those issues, and sometimes trying to get those resources to people. Sometimes those resources just don't even exist. I think when we're thinking in terms of health plans, even though there are some of those diagnoses that we know have higher levels of disparities, I think this really highlights that because some of these needs can be so broad, that narrowing it down to just one particular health diagnosis can be a great challenge when we're thinking in terms of equity. And if we try to think more in terms of point of service and the services that people who are living with some of these health challenges might need, especially amongst different communities, because as Camille had said, you know, the needs of somebody in Baltimore versus PG County or in Arundel County even are going to be very different, and the resources that they're able to get are going to be different. Excuse me. So I think that it helps to benefit us looking more at those point of services like we have been doing a little bit in this work group, thinking about how we can reduce cost sharings where we can for labs, for medications, for frequency of visits, for specialist visits, because some people with some diagnoses are going to need more visits than others. And I think, Matthew, you had your hand up.
I just want to add, I mean, thank you for that, Emily. I just want to add, I sort of mentioned this at the top of the meeting, you know, this idea of health-related social needs versus social determinants of health versus what we can do as a health plan, as CMS, as the department. I realize that we are in the business, though you guys are, that the plan is working to approach this, you know, from a services perspective versus a disease perspective. But historically, you know, our system, our healthcare system is set up to treat diseases. It's not set up to treat, you know, that's what ICD-10 codes are. That's what, you know, I mean, it's set up to treat disease, but we really need to treat more holistically the social determinants of communities writ large, of which these individuals sit, and their individual outcomes, health outcomes, are related to, you know, the societal dynamics in the broader sense. And that, to me, is what social determinants of health are. It's like, what is happening societally? Do I have bad water? Am I in Flint, Michigan? Do I have lead in my walls because I'm in Baltimore City? And do those result in disease that myself and my children have to mitigate and manage? And I know that we are limited in terms of what we can do. But, you know, and certainly plans and providers are limited in that. But I fundamentally believe that until we really start looking at those upstream drivers of health, then all of this feels just like lipstick on a pig on some level for me. So I think it's really important to sort of get as far upstream as we can within our wheelhouse and really try to get at the issue there. Who had a hand up? Lisa, I see your hand up.
Okay, thank you. When you all are mentioning these chronic conditions like asthma, cancer, HIV, obviously these are, the treatments for these are a lot of the prescription medications that are not only brand name, but specialty medications that are very high cost. So some of these communities, if they're not on Medicaid, but they're on a qualified health plan, such as a bronze plan, that may have a combined deductible or a high out-of-pocket maximum, that's sometimes a barrier to get those higher cost prescriptions that the doctor might require for those diseases. So taking a look at those prescriptions and the treatment, I think, would be something that you need to look at.
Thank you.
Thanks, Lisa. Any other thoughts for our guests today?
Well, a couple other things that we didn't get to with the slides is we didn't have any slides about mental health and behavioral health, and certainly those are issues where we probably have way more needs than insurance is designed to cover. I don't know what the answer to that is, but certainly it's an area to keep in mind. And then I think the intersection of multiple chronic diseases simultaneously, because it strikes me that people with diabetes actually are more likely to have hypertension than people without diabetes, even if you age adjust, because they have common risk factors. They tend to go together. And so designing a plan that not only is helpful to manage your one disease, but how does it manage your collection of related diseases like this kind of cardiometabolic cluster I think about with hypertension, diabetes, kidney disease, and all the related heart disease and cerebrovascular disease that goes with it. How do you build something that allows someone to afford to care for that cluster of multiple diseases, because those folks are going to be the high utilizers. That used to be about 2014 or so. The whole Camden hotspotting model was the rage. We kind of talk less about it now, but I think it's still very appropriate. 20% of the people result in 80% of the costs, and you can find people with incredibly high amounts of utilization of ED visits and hospital admissions, racking up lots of costs, which could be a fairly small number of people to try to intervene with if you can identify who they are and get to them, which is kind of what the HEZs were trying to do. So I think that whole notion of the high utilizer population, the multiple chronic disease population, is there something in plan design that we want to do that's unique to them? Clearly, they're going to be high cost patients. So how do we solve the problem of how do you design a plan that in some ways tries to minimize the patient share of cost so they can use it, but by doing that you're putting more burden on the insurer. You don't want the plan to be insolvent, because then it won't exist, which is not what we want either. So it's a challenge, but just some of the things to put on the table.
Yeah, great points. Well, thank you so much. This has been great for kind of looking at the bigger picture, health equity considerations in Maryland. Just really grateful for the two of you to be here today. Really appreciate it.
Thank you for the invitation. And Dr. Mann and I, Dr. Mann's, Dr. Mann keeps threatening to retire, and I am like panicked. But he is just such a wealth of information and knowledge and really commitment to these issues. And so he's available for anybody who would like to sort of, discuss in greater detail what he's presented today, as am I. Thank you so much for having us. All right.
Thank you so much.
We'll sign off. Take care.
We'll be in touch. Thank you so much.
Bye-bye.
Great.
Let me get myself off here a second. Let's see, out from there and out from here.
Hey. So for the rest of the call, I just have a couple next steps to go over. Okay, so thanks everyone for tuning in today. I hope that this the itch for more information on health equity in Maryland. We have another meeting in 2 weeks. The plan designs, our actuaries just today sent me a new version, so I'll send those with more in advance of our next meeting, more in advance than I sent them the last time I had around for you. So send those around, and next time we will talk about the feedback I've gotten on them, and we'll see if everyone feels ready to vote at that point. But if not, we have a meeting on September 3rd as well. And that would be the September 3rd meeting is the last meeting we have on the calendar, but we will probably convene again to talk about post-AD calendar adjustments. I see Ken asks for me to share the slides. Yes, I will share these slides, and they'll go on the Workgroup webpage on our website. And yeah, other kind of key milestones are that the recommendations of this work group will be presented at the Standing Advisory Committee on the 12th of September, and then to the board later that month. So that's the plan for next time. Talk about the updated draft list. So thanks again for tuning in. Let me know if you have any questions, and I'll be in touch.
Thanks,
Thank
Becca.
you.
Thank you.
Thank you.
Thank you.
Thank you.